All right, so thanks everyone for coming. It's my pleasure today to introduce Dr. Monica Agrawal. She's an incoming assistant professor at Duke University, joint between the Department of Computer Science and the Department of Biostatistics and Bioinformatics. Her research focuses on scalable clinical NLP and smarter electronic health records. Earlier this year, she completed a PhD in computer science at MIT, and she is a co-founder of Layer Health. So Dr. Agrawal, please take it away.
Thank you so much. Yeah, so as was described, I'm sort of in this transition period right now. So the work I'll be describing today was based on my PhD work at MIT, and I'll be at Duke starting in the fall. So electronic health records contain a wealth of patient data. So they've seen incredibly rapid adoption in the United States, and I assume also Canada. So with being in 28% of hospitals in 2011 to 96% today. And the thing is, the real-world evidences in electronic health records can really facilitate personalized medicine because clinical trials alone can't answer every question. So what do I mean by that? Let's consider a few questions. One, what drug would lead to the best outcome for this specific patient I'm seeing, given what I know about them so far? Or what is the patient's expected disease trajectory based on the trajectory of the disease we've seen? Or what adverse events might come from a given combination of drugs? If you try to answer what adverse events come from a drug combination in trial, you would just never have the population you needed because there's clear combinatorial explosion problems, even if you try to consider any pair of drugs. So as running example, let's just look at this first question of what drug would lead to the best outcome for this patient. So if we wanted to answer that question, what sorts of variables would we need? So one is we might need to know what specific disease a patient had. What was the status of that disease? So, when were they diagnosed? When did the disease get worse? What were the interventions you've already tried? So, what surgeries, what are the drugs that have already been figured out? What are the symptoms and side effects this patient has been experiencing? And what are confounding factors? So maybe because of their cirrhosis or congestive heart failure, there's some intervention you can't provide this patient. So the challenge here is many of these variables are not found in structured data, but instead trapped in messy free text clinical notes. So instead of having it in some sort of tabular form that you can export, this data is only found in clinical text. And that happens for a few different reasons. One is efficiency of documentation. So it's there's so many nuanced different clinical concepts. There's thousands of different possible symptoms that if you tried to make a doctor click check boxes for every single thing that was or wasn't present in a visit, one, it would take forever, and two, that's an intervention that's been tried, and they simply just kind of ignore those forms. So it's just simply faster for them to express their thoughts in free text rather than trying to fill out forms for each patient, which don't really capture all the nuance. A second reason is splintered care. So you guys can imagine, right now my health records live in Massachusetts, and when I move to North Carolina, I'll probably have kind of a new insurer, a new health system, and they're not going to have all my old notes necessarily. They could be faxed over, but there's a real issue of data interoperability of what happens when a patient moves. And what would usually occur is in my first new visit, I'll kind of describe all of my past history that's relevant to my new PCP. So then they'll have it in a note form, but they don't have access to all my old information off the bat. And finally, and I think really importantly, are deviations from the original care plan. So you can imagine, I get asked questions like, can't you just look at, what someone's been prescribed to figure out what drugs they've taken? And what's been prescribed are the drugs they should be taking. There's often kind of deviations because they had terrible side effects or they couldn't afford to pick up the drug. And for all these reasons, there's often non-trivial deviations between, what was pre-prescribed and what actually occurs. And those deviations are often, described in text based on a patient's conversation with their clinician. And in particular, when trying to think about how can we learn from healthcare data, capturing not just the norm, but it's particularly important to capture those deviations when things are not going as expected, because that's where there's a lot of interesting learnings for healthcare. So the next question I often get is, how messy can notes even be? So something like this is not something that would be so unreasonable to see in a clinical note. Something like PT progressed after 5 moles of carbotaxo for EC, will DC and discuss Pembro. So if we want to just start breaking this down, there's first kind of an expansion to understand what individual words are saying. So the fact that MOS is months, EC is endometrial cancer, DC here is discontinue and not discharge. From there, kind of, making sense of matching, what was the reason for each of the things mentioned, what's the status. So the fact that, the thing that was discontinued was the carboplatin and paclitaxel and not the pembrolizumab, even though they're mentioned in the same sentence. So there's kind of a layer of structuring around it. And then from there, we can sort of map that back to the giant timeline of what's going on with a specific patient at an instant in time. So the takeaway here is that there's kind of a lot of reasoning needed to sort of go from what clinical data we currently have to clinical data that's kind of useful for at scale, not just for an NLP perspective, but, to answer other questions in machine learning from, causal inference to reinforcement learning. So this is a really daunting task because a patient, so you can imagine a cancer patient easily goes in every 2 weeks to a month. So you can easily have hundreds of clinical notes that you need to transform into this timeline. And you have this for thousands of patients. So if you want to figure out, which patient is most similar to my patient and has good outcomes, you might need to do this for a large swath of patients to understand, who has the same comorbidities and has had, the same starting trajectory. So what's the status quo? So we want to get from unstructured clinical notes to structured data that's usable for a variety of medical research, both computational and otherwise. So what still happens largely today is a full chart review in which you have clinicians kind of manually going through and reading the records and structuring data. That's obviously not incredibly scalable. So another paradigm that's appeared over the last decade is doing a partial chart review followed by a machine learning or NLP model. And a lot of my early work, that was sort of the flow that my work took, which was there was a specific variable I wanted to extract. I used some set of labeled data. And I found that, often the same analyses that I had done with fully manual data could be achieved when you only do a partial chart review and then use machine learning to fill in the rest. But there are major issues here, and this partial chart review step is still a huge bottleneck. So one is that it's variable and setting specific. So for every single variable, you need to make new training data. And also every hospital sort of describes things differently. So it's often this transfer issue in that a model you build at one hospital or institution doesn't translate very well to another. There's still a large amount of annotation time that often goes into these, which is not very scalable for institutions that might not have the annotation firepower. And finally, this data is really sensitive and difficult to share across institutions. So if you think about something like chest x-rays, we've seen a lot of open source data sets in that space, because there's usually not the case where if someone saw your chest x-ray, they'd be able to immediately re-identify you. On the other hand, clinical notes often contain really personal information that could be used to tie back to a specific patient. And as a result, there's rightly so a lot of guidelines around that data sharing. So, labeling done at one school often won't be shared with another. So what my research has really been on during the PhD was, how can we scale clinical NLP to get around these bottlenecks? So one thing that I won't talk about today is how can we optimize annotation effort instead of viewing it as only a human or an AI problem through a mixture of human AI teams, and how can we optimize these and what are the possible downfalls? The second is how can we design models that leverage unlabeled data so you don't need kind of data hungry algorithms. The next step very clearly became how can we leverage large language models starting in about 2021 or so. And finally, throughout the PhD, we were kind of taking a step back and thinking about, instead of assuming that we're going to get this sort of garbage in, how can we turn it into something more useful? There's a question of how can we create cleaner clinical notes to start off with, so we don't have that sort of ugly paragraph I showed you earlier as our starting point. And I'll talk about a subset of these today, and people should feel free to interrupt and ask questions as they want to. So first, I'll be talking about how can we design label-efficient algorithms. So the idea here is, how can we take this machine learning or NLP model and make it so that you have to do much less chart review compared to before, so the overhead needed in annotation is very low to create your training data set. So the issue usually is if you have a small data set, you have a low signal to noise ratio. And this is for a few different reasons. So in text, you have really high dimensional inputs. So unlike something that might have 20 variables, you can easily have tens of thousands of different tokens in text. There are multiple ways to say the same thing. So, if you want to say that a patient has a fever, you can say that they have a fever, they're febrile, they have pyrexia, any degree over 100 in Fahrenheit or over like 39 in Celsius. There's all these different ways where the same underlying concept can be described in many ways. There's also a single way to say different things. So there's a lot of abbreviations in clinical text. So PT can mean a whole host of things, as can MS. And finally, there's a lot of irrelevant information. So often the task you might care about, whether a patient has hypertension, might be slipped in somewhere as history of HTN amidst a very long note. And often, benchmarks in NLP have traditionally been on sort of like sentence or paragraph level tasks. We're obviously now seeing the advent of language models that can take much longer context. But due to the amount of irrelevant information, often there's a low signal to noise ratio if you just have a small amount of annotated data. And the way this usually is overcome is with kind of better deep representations. So to give an example, at a word level, if we want to disambiguate the different meanings of depression from the mental health disorder to the EKG, meaning to like a physical depression of an organ, you might want to cluster that way to separate. You can also have representations that ideally separate things at a phrase level. So in this example, we have different pieces of text describing a radiology report for a cancer patient. And ideally, what we want to do is, with an ideal representation, separate the patients that have progressing disease on the bottom from those with stable disease, but also be able to separate the patients with early stage disease to patients that have later stage disease. So an ideal representation is flexible enough to then be used for multiple downstream problems. So the framework here that's quite general is you have some high dimensional input, whether it's an image or a text, you have an embedding model that leads to a low dimensional representation. And with that low dimensional representation, you can have a classifier with much less labeled data to give you your answer. So the questions is, how can we learn these good representations without labeled data? So representation learning is a large and thriving field. And in representation learning, there's a concept of self-supervision, in which you leverage the implicit structure of unlabeled data to learn useful representations. So here's an example. with text where you have a masked prediction objective. So this is what underlies BERT, which was a model that was very popular when it came on the scene back in 2018. And the way BERT is trained is you don't have any labels, but you learn representations by hiding a word and getting the model to predict what the missing word is. And in doing so, you don't need any labeled data, and you can fill in, and you can learn just to do that fill-in task. And all you need is unstructured text. But what we actually see is that in clinical NLP, this doesn't actually do particularly well. So if we compare it to Bag of Words, even in the original paper, there's a small bump of 0.03 in AUC. And a lot of other works, it doesn't do that much better than something like a logistic regression or a random forest, which is much simpler, much easier to deploy, requires much less compute. So then there's really this question to ask of, when we're learning these representations, are we recovering the relevant signal? So the work I was doing was, how can we conduct kind of more grounded self-supervision, specifically for chronic disease, that recovers the signal we care about? So in this case, I'm going to give an example of trying to identify cancer progression. So what you want to do here is leverage temporality. So, and that's the structure that we have that we can sort of play with. So let's say we have ordered longitudinal notes. So each patient does not have one note. Each patient can have, 50 notes. And let's say the lightest notes are the early notes and the darker notes are the later notes. And the question is, what happens if we scramble these notes? Can the model learn to reorder? And the idea is, in doing that reordering, it's going to have to learn something about how does like a disease progress and what medicine looks like. And this is something that we called order contrastive pre-training, or OCP. So the way it's instantiated is very simple. You train a representation to predict if a pair is in the correct order or in the incorrect order. So whether the lighter note comes before or after the darker note. And the intuition here is that in doing this dimensionality reduction, we're getting to what are called time irreversible features that signal disease progression. So this is a medical example. So the idea is that if you have these two notes, the thing that really matters in this case is the evidence of metastases. And if you learn to kind of focus attention on those, you can learn how to order these. And there's a lot of fluff on follow-up, and none of that is actually important to what's occurring in the note. So this still follows what we were saying before, where you have a high dimensional input, you want to get to a low dimensional representation. So we also grounded this in theory with a toy model, saying that a note consists of these time irreversible features. In this case, something like unchanged bone mets, which really talks about the patient's underlying disease. There's noisy versions of those features, things like recommends physical therapy. In this case, the physical therapy kind of hints at, the patient's state, but it might not be directly talking about the patient's cancer. And then we have background features, things like, note sections and follow-ups that we see across the board, which often this kind of background information takes up a huge fraction of the note, but is not really useful for a downstream task. So what we show is that assuming that our downstream task we care about is a function of those features in S alone, this order contrastive model can discover S with high probability. And I'm not going to go through the proof today, it lowers the upper bound on labeled sample complexity, which means, you don't need as much labeled data to get the same result, which is exactly what we were hoping for. So we did real world experiments that were both linear and deep. I think for time, I might just talk about the deep experiments. So the goal here, again, is to classify radiology notes as whether they show evidence of cancer disease progression. And the question is, do we learn useful representations? So first, we pre-train a representation using transformers to focus the attention of our model. And we then use those embeddings for a downstream task. And the way attention works, for those of you who are not in NLP, is essentially you can imagine instead of having something that hard includes or excludes a feature, you have a soft weighting on how much attention is placed on different words. So our goal would be to have higher attention on the words like unchanged bone mets and lower attention on words like follow up. And what we find is that OCP can learn really good deep representations. So with 1/16 of our training data, so training data for only 5 patients, we find that we can get an AUC of 0.81. In comparison, if we were trying to use, an out-of-the-box BERT or a clinically masked BERT, we only get 0.59 or 0.71. So there's a really stark difference in not just doing pre-training, but doing a pre-training that's really targeted towards the task. Now, as we get to having all of the data, that effect diminishes. So we only get, a bump of 0.03 compared to sort of doing the general task. But labeling, something like 10 notes for 80 patients, 800 notes can take a significant amount of clinical time, since it's not a task that can be, for example, farmed out to Mechanical Turk due to the domain knowledge needed. And what we can also do is have interpretability on, what is this learning? And we find that high attention was placed on the words we might expect to talk about kind of the disease's evolution. So the takeaway here is that, yes, we can do disease progression classification with very few labels, but the much wider takeaway is that you can really leverage the shape of your specific data to advance past generic heuristics when doing self-supervision, and that can be really powerful to do better than sort of the out-of-the-box pre-trainings that are offered if there's something particular about your data that you can leverage. And I just want to call out, there was another paper that kind of currently showed that this worked well on medical imaging data. So, more recently, there's a question of how can we instead leverage large language models? So this was work that was at EMNLP now 2 years ago, which feels like ancient in LLM time. But the idea is, how can we kind of bypass the entire partial chart review and ML-NLP model to just kind of replace it with a single purpose large language model that can provide us structured data. So the question is, are the same things that are kind of being used kind of in pop culture enough to get us to what we need in terms of structured views of a patient's record? So the first hurdle here is avoiding label leakage. So one thing that people should be cognizant of when using any existing public label data set is that it could suffer from label leakage. And by label leakage, what I mean is, GPT or whatever model has actually seen the answers to whatever you're benchmarking. And to sort of get around that, and the fact that at the time we did the study, there was no HIPAA compliant way to use LLMs, we re-annotated a publicly available data set to release new few-shot extraction data sets that are available online. And with these, we had no fear, at least at the time of benchmarking, that the model, that GPT could have seen the answers before. And there have been studies that have shown that, on certain tasks, GPT performs better on things that had been on the internet as of, 2021 or 2022 versus things that occurred more recently. The second hurdle, and this is one that I think has become a lot more commonplace, is evidence-backed output. So let's say our goal is to list medications as well as several of their attributes, and we have some input. We might want a completion that, gives us a nice little structured form, but what we'll often get is something like the medication taken is metformin for the reason of diabetes at a dosage of 500 milligrams. And this has 2 issues. One is that it's narrative, so then you still have to go from what's written to something that's usable. But the second are hallucinations. So here it infers that the reason for the metformin is diabetes, And diabetes is definitely the most common indication of metformin, but it's not the only reason people take metformin. There's also prediabetes and PCOS. And what we don't want is for sort of the inferences of the model to necessarily populate our databases, because that could kind of skew numbers. And this was a really easy fix, but at the time was not yet done, of a prompting strategy where we kind of showed it the format we wanted it to output. So there's a few elements here. One is that we provided an example with exactly what output format we wanted. And then we forced it to quote. So in forcing it to quote, it decreased the hallucination because it now had to, it couldn't, quote the word diabetes. And even though nothing was forcing the generated text in blue to not hallucinate, empirically, this is enough to decrease that hallucination rate. But the largest hurdle is likely deployability. So anyone who sort of played around with GPT has likely found that the model can be really sensitive to prompt wording and exactly how you ask the question, and that the models are often kind of miscalibrated and often overconfident. So there's kind of this push and pull with these commercial large language models where, sometimes they make probabilities available of, what was the probability the model said yes versus no, and you can use that to gauge, how confident the model might be. Increasingly, they're actually making those black box. So we don't actually have that same view into what was the emission probability for any word. So the solution we have is to treat the language model outputs as weak labels, and I'll talk about what that means. So let's say you have some purple data set. We can send it to the LLM and have the LLM classify each of the documents. So let's just say there's 3 different classes, each represented by a color. What we then want to do is identify the outputs where the model is more likely to be accurate. And I'm going to describe on the next slide how we do that. But let's say we have this procedure where we can try to guess, not using the model's own sense of confidence, where the model is accurate. We can then train a much smaller model on those confident outputs. And then we can now actually run that smaller model on the same data set, so that same purple data set, or on new data sets. There might be some red data set that you don't even want to send online for privacy reasons. And what we find is that it can actually fix errors that the model had made originally on the purple data set, in addition to running on new data. So then the real question is, how do we do this step 2? Given that we can't, trust their own outputs or confidences. So the way this works is, so let's just say that stripes versus solids are, the classes that the LLM classify these data points as. We now want to embed these examples with some other phi of X. So this could be some other language model that's small and that you can fit on, local computing infrastructure. So this could be something like a BERT model, for example. What you then do is make a k-nearest neighbors graph in that new space. So you say, for each of these data points, what are the data points that are close to it? And then what you do is select the examples from the most homogeneous regions. So by sort of avoiding those in the middle, where they're kind of connected to both the striped and the solid points, is you kind of get rid of the space in which the model is not sure and you're on the edge. And by getting rid of those points, we're training on a more accurate subset of the data. And as a result, you can get even better performance. I want to kind of credit my lab mate, Hunter Lang here, who really was the push behind a lot of this work. And he has this great NeurIPS paper from 2022 that shows how the same procedure can be really helpful across a wide variety of data sets. But, as a result, if we try to do acronym disambiguation, so something like, I give you PT, what does it mean? There are many meanings. You don't have labeled data. Even out of the box, GPT, and this is, even an old version of GPT, 2 years old now, in purple, can widely outperform the one in red. But in green, we now add this weak supervision step. And what we see is that, accuracy goes up non-trivially, as does the F1 or disambiguation power. And similarly, we see that even compared to a supervised baseline in red, GPT-3 does significantly, does just as well or significantly better. So now I want to take a step back, because I don't think it's particularly surprising to those in the audience that, GPT is doing well on kind of interpreting text. But I think what's a really interesting question to ask is, what are these models training on? Because unlike, something like Wikipedia, clinical text is, usually quite locked down, and it's not something that you're going to find online in, large swaths. There's a lot of privacy around clinical text data. So it's really interesting to try to understand, why are these models performing well, given that we don't expect the same EHR data to be necessarily present in their training distribution. And there's kind of, two motivations. One is, where might it do or not do well based on what we know about the training data? But also, if we want to train our own models, how can we figure out, what data sources we might want to augment with based on our findings? So both for, better understanding existing models and towards creating new models. And as motivation, if we look at clinical language models right now, all that's really important to look at is that it's often trained on a single data set from a single, hospital. And as I described earlier, there's often huge transfer learning issues going from one hospital to another. So there's a question of, GPT and these models that are not trained hospital specific are doing quite well. So what is the data it's drawing on that maybe we can as well? And another piece of motivation is an ICML paper that I was not a part of last year that showed that a language model's ability to answer a fact-based question relates to how many documents with that question were seen during pre-training, and they show a pretty strong relationship. And as a result, it's interesting for us to think about, how can we augment data as needed based on this information. So there's a question of how can we study pre-training data? So I do not have access to GPT for training data, but we can use proxies. So 60% of GPT-3's training data was a filtered set of Common Crawl. And Common Crawl is kind of a crawl over the internet. So as a proxy, we investigated C4. So C4 is a data set from Google, the colossal clean crawled corpus. It was used to make some language models a few years ago, like T5. And because it kind of contained some of the same elements, we thought it would be useful as a proxy to investigate. And what we wanted to look at was for things like technical jargon, like prothrombin time is shortened as PT, or more colloquial jargon like that you might never find in a research paper, like, for time, doctors write fracture as FX. We wanted to analyze sources in which the pairs appeared and how frequently that occurred. And what we find is that there's this really interesting mix across, research articles, which are what people usually think of, things like PubMed, but also patient health resources, websites selling health products, and really interestingly, clinician forums and patient forums where they're describing their own experience for this colloquial jargon. And while you might think, only 6% are described by patients, if you look at, specific terms like carbo really means carboplatin, or AMA in this context means advanced maternal age, those are largely found in sort of the patient blogs and forums, which is just to say that as we think about, understanding pre-training data, there's kind of wide heterogeneity in what's important for different use cases. And this can really inform, and I think a similar, not even in medicine, can inform how do we create training data, pre-training data for specialized domain tasks. And what's also interesting is, things like PT and physical therapy, occur tens of thousands of times. That makes sense. Whereas, something like NAD for nothing abnormal detected only appears 14 times, whereas PR for per rectum never appears. It's been filtered out by content filters. And that has really interesting implications to think about, the effect of content filtering on things like genitourinary diseases. Another analysis back in 2021 found that medical information was commonly excluded by the filtering process. So the takeaways are the reasoning capabilities within LLMs could really transform this entire paradigm of how we understand what happens in clinical data. Naive application of these models is often insufficient, so we developed further techniques to boost performance. But importantly, it's important to really understand what's the clinical data look like that underlies these LLMs in the first place. So finally, I want to talk about, how can we actually change how we think about clinical documentation entirely? So, I've been talking about how can we get from these really messy clinical notes to structured data. But instead, how can we actually think before the clinical notes were even created back to the documentation process? So electronic health records have major usability issues. So this is an article from 5.5 years ago on why doctors hate their computers. And there's two major reasons. I mean, there's many reasons, but there's, two reasons that we try to tackle. One is the amount of time needed to enter data. So they spend a huge amount of time entering data. And then a huge amount of time then trying to retrieve data that they or other doctors had entered in the past. So the challenge of data entry is not new. So this is a ACL or computational linguistics paper from 1975 on the linguistic characteristics of medical notes. And it finds that they are a compressed type of linguistic material that have to be brief to save time or effort. So this is, a long-running problem of medical notes being incredibly short and therefore difficult for downstream analysis. So our solution was to kind of streamline the data entry process via a contextual autocomplete. So this autocomplete is personalized to each patient based on what had previously occurred in that patient's prior clinical notes. And basically, as you type, it automatically normalizes concepts to ontologies as the note is being written. And basically what happens is we get kind of cleaner data, but it also at the same time decreases documentation burden because you don't have to type as much as you did previously. And as sources of supervision, we use prior notes, kind of their triage, the chief complaint, all of these other sources of data further up in the clinical process, and use that to predict what would be written in doctor's notes. And what we found, and I want to give a lot of credit here to Divya Gopinath and Luke Murray, who were really involved in this deployment, that you could dramatically reduce the keystroke burden of data entry in a live setting. So we tried this live in the emergency department at a Boston area hospital. So the second challenge I had mentioned was information retrieval. So and this is a problem that's particularly pertinent in the emergency department where a patient comes in and you don't have any prior knowledge of that patient the way you might with a PCP. So to understand what's the best next step in terms of providing good care, you have to manually synthesize all this past data into a data-driven narrative. So these are things like past labs, past medications, relevant notes, or relevant imaging. And this whole phenomenon is called death by 1,000 clicks, because in order to get the information you need to treat a patient, you have to kind of click through all these different windows, searching for information. So our solution was to streamline the information retrieval. So as you auto-completed something, say the AFib concept from before, we would automatically surface information that might be useful. such as, here's past drugs the patient's been on. And at the same time, we can fill in redundant information. So there's a lot of sections of notes that are overlapping. And what we can do is fill in things that have already been described in one section, so you don't have to repeat documentation effort. So MedNotes, led by Luke Murray, was designed in this year-long iterative process with a clinician and their scribes across 1,200 patients, and then evaluated in a month-long deployment with 4 scribes and over 200 patients. And in a user questionnaire, on median, people would use it frequently, it had a quick learning curve, and they found that it was easy to use. So the takeaway here is that via redesign of the electronic health record, it's possible to simultaneously obtain cleaner data as a natural byproduct and reduce physician workload. And that these features can be integrated into live workflows via careful opt-in design. So what was really important was that we weren't forcing any change on the clinicians, but rather it was something where a feature could be enabled if they wanted it, but if they wanted to ignore everything, they could proceed as normal. And that was really important for getting buy-in because it can be really disruptive to workflows if you introduce a new process. And I just want to end with the fact that, large language models are now being explored for generation of wider clinical text. So, we described something that was very constrained, where it was only generating very structured sections or only, the next word. And there's this kind of wider issue or concern about automation bias. So as we move towards incorporating AI to speed up clinical workflows, it's important us to think about how can we minimize unintended consequences, both in medicine and otherwise. So here's a swath of papers from, including from over a decade ago, showing that as you add automation in different processes, whether it's prescriptions or diagnosis, it can unduly influence the decision maker. So, one piece of work that was led by my master's student Sharon Zhang last year was trying to better understand what is the data generation process. So to take a step back from what's shown on this slide, we often think about, data generation, like note generation or text generation as this really monolithic piece in which a lot of information is generated at once. But what we actually find is it's often written in different sections. So for example, in this emergency department note here, it was actually written in 3 different parts. And during each of these different parts, they were looking at different notes. So they were looking at, these blue notes while writing the beginning. They looked at this red note, didn't write anything, referenced the yellow notes when writing that other section, and then finally followed up with more information. So when we think about text generation, it's not merely about, what the final product is, but really the process of writing. And I think it's really important as, NLP as a whole moves towards text generation to really understand, what are the processes that were originally taking place and how can we make sure, nothing is left behind as that transition occurs. So for example, on average, these ED visits had 7 writing sessions with 8 retrieved notes. And with that, I'm happy to stop and take any questions people might have.
All right, let's thank Dr. Agrawal.